Our group decided to go with hereditary spastic paraplegia, otherwise known as HSP, because of its connection to one of our group mates, Emily Mickelsen. Over the summer, Emily worked as a CNA for a student with hereditary spastic paraplegia and got an insight on the daily struggles that come with not only being a disabled student, but also what the school is able to do as far as accommodations. HSP, otherwise known as familial spastic paraparesis, is a collective group of neurodegenerative disorders that affects the neurons of the spinal cord, the corticospinal tract, and the posticular columns. This disease can be characterized by progressive weakness and spasticity in the lower limbs. Before we get into the gritty details of the disease, let's dive into a brief history of the disease. We start in the year 1880 in the Baltic German region, now known as Estonia and Latvia for your geography junkies. It was here that the first cases of HSP were documented. Neurologist Ernst Adolf Gustav Gottfried von Strumpel worked with two siblings whose symptoms manifested at 37 and 56 years of age. They showed pure clinical signs of spastic paraplegia, and upon investigation via autopsy, neurodegeneration was discovered in the lateral cortical spinal tract, fasciculus gracilis, and the spinal cerebellar tract. 8 years later, Maurice Lorrain published a more detailed contribution to the anatomical and clinical features of HSP. For Strumpel's and Lorrain's discoveries, HSP is also known as Strumpel-Lorrain disease. Just like many other diseases, more information became available as technology advanced. During the 1980s, almost 100 years later after its documentation, Anita Harding published the largest clinical study of HSP involving 22 families. The data she collected provided healthcare providers with clearer clinical definitions so that recognition and diagnosis of the disease could be improved. In the last 10 years, scientists have been able to identify the genes responsible for the various symptoms of HSP. Similar to DMD, HSP has a subtle onset. It starts with a slightly abnormal gait and slight weakness in the lower limbs. However, symptoms can begin at any age, from infancy to upwards of 6 years of age. As the disease progresses, canes, walkers, and wheelchairs may be needed until the patient is non-ambulatory. HSP is unique in the fact that there are two classifications, pure and complex. Pure HSP involves difficulty walking, whether it's non-progressive or progressive, the use of canes, walkers, or wheelchairs, urinary urgency, lower limb paresthesia, and the functions of chewing, speech, and swallowing are preserved. Complex HSP has the symptoms of pure HSP with the addition of ataxia, seizures, intellectual disability, dementia, muscle atrophy, extrapyramidal disturbance, and peripheral neuropathy. To accurately diagnose the disease, an MRI scan, cerebrospinal fluid test, nerve conduction exam, EMG, family history, and genetic testing may be ordered. The genetic testing would be the most accurate test, however its low accessibility makes it hard to accomplish for many families. Its similar clinical presentation, specifically the shared trait of lower limb weakness, is one of the reasons why we chose this disease. Furthermore, the following speaker, Emily, can give a first-hand account of working with an individual with this disease.
This past summer, I worked with a student in law school who was experiencing hereditary spastic paraplegia. I helped her with simple day-to-day activities as well as administered her daily treatments and medication. Her form of hereditary spastic paraplegia left her wheelchair-bound completely. She had very minimal movement in her arms and a slight speech abnormality. It had also affected her spine, and she had already undergone multiple surgeries throughout her childhood to try to correct her spinal alignment. Currently, she still has severe scoliosis and leans to the right a bit, but has a specialized wheelchair to support her best in that position. Her muscle weakness resulted in a stunted growth, and she only weighed about 70 pounds. Even though her movement was extremely compromised, she had no intellectual disabilities. Hereditary spastic paraplegia does not shorten lifespan, so she has many goals, one being a lawyer, and was able to do many different abroad programs. I thought that it was amazing that the programs she entered were accommodating to her disability. For example, she needs certain accommodations on the plane for seating because she cannot sit in the regular seats. She also needs an aide with her at all times to help with certain activities and monitor her health. She even has an overnight aide, which I never did personally, but was told that it was just in case she had breathing problems during the night or needed to be taken to the hospital. It was exciting for me to see that she was able to do an entire summer in Korea and study what she was passionate about. Each day when I was on call working with her, I would go to her apartment in the morning. Once the on-morning shift had arrived, the night aide would be able to leave. She had a specialized remote that allowed her to open the door to her apartment from her bed, so that when I came, I did not need a key to get in. I would turn on the lights and get her medicine and morning activities started. She had a feeding tube, so I would first feed her through that as well as put her dissolved pills from the night before down the tube. Although she was able to eat using her mouth, the feeding tube made it easier for her to get calorically high and nutritionally dense food in a small liquid form. Each day, she had about 10 different pills that she needed to take to help with muscle function, lung efficacy, and nutrition management. There was also one medicine that needed to be refrigerated and was given once a day through the feeding tube in the morning. After feeding her, I would get out all the necessary supplies to change the bandage around her feeding tube. She was able to do all of this herself, and I would just have to lay everything out for her. After changing the bandage, I would start her 2 breathing treatments. One was albuterol, and was administered by putting a mask over her mouth and having a machine diffuse the liquid as she would breathe it in. The other was a type of compression body sleeve that would go over her chest area and deliver pumps of force every second to promote lung function. Altogether, the breathing treatments took about 15 minutes from start to finish. Then I would change her and put on her leg braces, which helped prevent muscle atrophy in her legs and keep them as straight as possible. She was able to brush her teeth and put her contacts in on her own as long as I got everything out necessary for her. She had a bed that was remote controlled so that it was able to mold to her needs of sitting up or lying down. She also had a specialized pillow molded to her head angle so that it could stay supported. After getting ready for the day, I would carry her into her chair. This was a harder process because I had never done it before, and it took me a couple tries to get the hang of it. Once everything was done, I would do laundry or take out the trash or clean, depending on what she needed for the day. The next step was to go to class. I would walk with her to the law school until we got into the classroom, and would open doors necessary for her. The school was extremely accommodating when it came to seating for her in the classroom. Due to the height and position of her chair, she needed a specialized table to be able to do work on. I went with her to meet with the disability counselor of the law school, and we went to all of her classes and tried out different tables and heights to make sure that they worked for her. We also went around the law school and told them what would be needed to accommodate her in the bathroom and the study area. While this was done a bit late, it was done. Once we would get to class, I would wipe down the table for her. Sanitizing everything was always extremely important because she was immunocompromised. After wiping down the table, I would get out all of her necessary books for class and position them for her properly. Then I would leave her for class and come back when she texted me. We would then pack up her bags and head back to the apartment. If she needed to do any additional things in the building, for example, get textbooks for do printing, I would do that for her as well. At the beginning of classes, she was able to get a remote that opened all the doors for her if there was not someone there to assist her, which I thought was wonderful. After class, we would do midday feeding and medications, but no more breathing treatments until nighttime. Day-to-day things would vary for what came after that. She often had to work, take a nap, or go to a doctor's appointment, and I would tag along. This was a very typical schedule for morning and the afternoon shift. She almost always had more than one class a day, so the same class process was repeated for the following class. The nighttime shift looked a little different. Most nights, 2 people would come in to help her shower. She had a specialized waterproof shower wheelchair, which was not remote control, so we would push her around in it. Her shower was modified to fit her wheelchair, and the head of the shower was detachable to make it easy to wash her. After showering, we would feed her dinner once again through the feeding tube and do her breathing treatments. During this time, I would set up her medication for tomorrow and place them together in a cup with water so that they would be able to dissolve for administration through her feeding tube the next morning. Before she went to bed, I would hook up her feeding tube to a feeding bag that had a regulated drip time of the peptide food that she had during the day, and then be on my way. This experience opened my eyes in so many ways. Being an able-bodied student at a university, all the obstacles that must be overcome for disabled students while pursuing a degree never passed my mind. I hope to raise more awareness around all disabilities in general, and that schools implement more accommodations to promote equality for all.
There are various similarities and differences between hereditary spastic paraplegia and Duchenne muscular dystrophy. Both diseases result in muscular weakness, which leads to them having some similar symptoms. Early-on symptoms for both include muscle weakness, muscle fatigue, and gait abnormalities. Individuals with either disorder often exhibit toe walking and increased trunk movement during walking as a result of weak lower leg muscles and hip abductors. Because of this, a big therapeutic focus for both include preventing contractures through daily stretching and maintaining muscle tone. Casts and splints are often used to maintain the stretch in muscles. Scoliosis is a strong concern for both due to muscle weakness and imbalances. This makes specialized wheelchairs really important as they help maintain posture. Hydrotherapy is also a beneficial therapeutic tool for both diseases. This is a great way to remove stress on muscles and joints while also providing a means to increase muscle tone and work on range of motion. While the muscular impacts of both diseases result in various similarities, the differences in the mechanisms of the diseases result in differences in some treatment approaches. Hereditary spastic paraplegia is the result of degeneration of nerves that deliver messages from the brain to the muscles, especially in the lateral cortical-spinal tract and the spinocerebellar tract. On the other hand, Duchenne muscular dystrophy is caused by dysfunctional dystrophin protein in muscle cells that results in sarcolemmal weakness. Strength training is often encouraged if possible for patients with hereditary spastic paraplegia because increased muscle damage is not a concern. This is not suggested for DMD patients because more muscular stress would result in increased damage and increased fibrosis. In addition, medicinal treatments of hereditary spastic paraplegia focus on the use of muscle relaxants to reduce muscle spasticity, while those of Duchenne muscular dystrophy often focus on the use of corticosteroids to increase strength and slow down progress of muscle damage. Finally, most hereditary spastic paraplegia patients have a normal life expectancy, while DMD patients have a severely shortened lifespan. Overall, we see that despite the disease that is causing the disability, these individuals can have happy, meaningful, and impactful lives. There are so many things we take for granted that others need assistance or accommodations for. We see with the previously discussed individual that she is extremely dependent on the help of others, emphasizing the importance of individuals and our society as a whole to help these people. Her life is very different because of her physical disability. She needs 24/7 care, and she needs assistance with almost every activity involving physical movement. It is important to increase awareness regarding disabilities and continue to improve how accessible our society is for individuals with disabilities. While it was great how the professors and administrators of her school were willing to make accommodations for her, she still has to put in all this extra effort to make sure the school is ready to have her and to get the education she wants. Despite these obstacles, we also see how she is driven, passionate, and impacting the world around her in a positive way. It is important that all disabled individuals can have the opportunity to achieve what they want readily available to them.